Welcome, everybody. I'd like to show my respect and acknowledge the traditional custodians of the land that we're meeting on in Australia today, wherever you may be, and pay respects to them and their culture, and to elders both past, present, and emerging. Looks like it's going to be a really exciting day. Yesterday was fantastic. Great lineup today. Welcome to our friends from overseas, John from Canada, and I missed the person from South America. Welcome along. And do we have anybody else from overseas? Anybody? No? Okay. Yep, it's great. All right. Well, look, I'm sure we're all going to have a great day. I'm going to hand over to James Smith now, who's chairing this first session this morning.
Hi, and welcome all, and thanks very much for the introductions to Greg and Glenn. I'd also like to acknowledge the land I'm meeting on is that of the Larrakia people and pay respects to elders past, present and emerging. I'm super excited about today's panel discussion. We're going to hear a little short presentation from Professor John Oliffe at the University of British Columbia. For those of you who don't know John, he's been working in the field of men's health promotion and masculinities for a good couple of decades now, I'd say. And many of you will be really familiar with his work, so it's really exciting to have him joining us all the way from Canada. We'll also be hearing from Professor Leigh Kinsman, Dr. Brendan Quinn and Dr. Amy Steele as well. So without any further ado, I will hand it over to John to start us off on our session around building men's health literacy and what that means. It's a very contested space. So over to you, John.
Thanks, James. Always nice to be back in Australia, if only virtually. So yeah, like they mentioned, I'm coming out of Vancouver today, and it's sunny. Can you believe it? And just want to acknowledge we're gathered on the traditional ancestral and unceded territory of the Musqueam people here. And if I can just share my screen, I can get a few PowerPoints going here and just give you a bit of an overview of my perspective, at least on health literacy. Okay, the slides good. Can you see them, James? We all good?
I can see them at my end, so I'm assuming everybody else can.
Mm-hmm.
Good on you, mate. Thank you. So yeah, health literacy. A disclaimer first and foremost is that I'm not an expert in health literacy, but I've been really interested in it because I believe it's a really important pathway towards health promotion, and I also think it's got some important nuances around destigmatizing. It comes from a place though that is around a deficit discourse. So you know, it's almost a hangover of Courtney's work out of 2000 that we sort of have this thing where we say, oh, guys don't really know the language of health and illness. So it's their estrangement from health and all things related to it in their health practices. You know, so this little note that I share with you, like it's only 4 or 5 years old, this campaign, it's out of the States. And it's shaming guys about, you know, what they don't know will actually kill them. And of course, guys buy into this in all sorts of ways because there's a whole parody around this. So it's disappointing because it's empirically not true, but it also sends a bit of a message that guys are estranged from their health. And I think that in health literacy, we see it all the time, that you're not expected to know the language. So I want to talk a little bit about that today. As I said at the front end, I reckon if you do health literacy well, it is a pathway to health promotion. But if you can't read the signs and you don't know the way and you can't map a destination, it's really, really hard to do. So health literacy used to be a bit of a dreary silo back in the day, but I think it's come a long way. I first sort of got exposed to it. I was doing some work with prostate cancer support groups, and I went in and, you know, I had 20 years background as an ER nurse, And so I sort of thought I knew language, and I was so surprised by the ways in which these guys spoke. They spoke in numbers around PSA, around Gleason, and these were prostate cancer support groups, volunteer run, free, and attracting about 5% of all the guys who were diagnosed with prostate cancer. So we've got 100 strong of them here in Canada, similar numbers, I believe, in Australia. And they kind of have this parody around, oh, you know, welcome to the club that no one wanted to join, but they do a really nice job of orientating guys to the language that they will need to be able to converse in the health encounters with their urologist, radiation oncologist, whoever the specialist is. They do a really nice job of that, and contextualizing, you know, a lot of the words that we kind of use routinely in a clinical base. So I was really kind of a bit struck by how they were teaching this language, because in fact they taught me a lot around the language, because it wasn't necessarily, I wasn't seeing a lot of prostate cancer in the emerge room, but you know, again, I sort of had a background, taught me a great deal. I think when you think about this example, there's a few things. One is about human connection. Literacy just can't be for the sake of rote learning words. It has to have a context, and usually that comes with a human element. You know, those guys really needed to know their PSA. It was like a calling card that they would actually exchange numbers. It would be their PSAs talking about, you know, their latest checkup and where they were headed. Gleason scores alike as well. There's lay ways of helping people understand language, and they do a really nice job of that, but they augmented it really well as well by bringing in healthcare professionals to kind of talk about their work. So clinicians were routinely coming in there, and they were using the language, and by extension teaching the language as well. I think numeracy was something that surprised me, because literacy is one thing, but numeracy is another. And the way they treat numbers was really interesting to me. One thing I'd say is they used to talk about 15% of the guys who had prostatectomy would experience urinary incontinence. And of course, the majority of the guys would put themselves in the 85% that wouldn't experience that as a precursor to having a decision around treatment. You know, so it just was so fascinating about how people treated the numbers, because percentages don't always really help people understand the risks that are involved and some of the outcomes that might occur, especially, you know, the way we measure urinary incontinence too, over 18 months usually with a lot of our trials. So what struck me as well is they learned health literacy through illness. So I thought that was kind of neat, because there was a context there, and most guys are experiencing prostate cancer as a chronic illness. So there was an unfolding of materials that they were learning. I sort of got some time on my hands and did a little scoping review, and it was so fascinating. I wanted to look at health literacy in the context of guys, and you know, really, this is what we found. You know, most of the health literacy studies really focused on medical knowledge of disease context, including prostate and colon cancers. They were the main ones. But there was diversity in evidence regards, you know, the conceptual frameworks and or the methods and measures used for evaluating, you know, men's health literacy. So, you know, there wasn't a lot of studies that we reviewed, because very few disaggregated guys or focused entirely on guys. And the fact that most of them were prostate cancer, you know, sex specific. So it was, you know, by default going to be guys in that context. So just to say that I don't think the field's come a long way. I think it's kind of, it's starting to take on a bit of a life, really important for how we conceptualize it. One of the things I learned early on is that, you know, just akin to Connell, you know, there's a plurality of how we know health literacy. So I started to do some work with veterans who were coming back from war, and we run a program out here at UBC. It's veterans reacclimatizing to civilian life. And the language that's used is really so much about language they know. So it plays directly to what they would ordinarily say. So they don't talk about post-traumatic stress disorder. They don't talk about counselling psychology, even though that's what this is. And what it does, it brings guys into a group to talk about and work through the traumas that they've experienced in reacclimatizing to civilian life. Really well done. There's like tiers, there's the whole thing, because they do a therapeutic reenactment. So they go through the traumas and they act them out within the group. And so that's release. You know, when you cry, it's release. You're releasing and you're dropping the baggage. So there's some other colourful terms I won't share with you, but it really works because they're talking to the process by which these veterans are transitioning back to civilian life. And it was such a nice reminder about working with guys kind of where they're at. The e-health space has always fascinated me as well. You know, so 75% of the people who were looking to quit smoking that went to this website were women. And we looked at the website and went, yeah, like it does in many ways. It doesn't look like it's for guys. The imagery, the colours, you know, so again, just the aesthetics of this. So we built them one. This is still going, this one, Quit Now Men. And we just built it in black and white. We did a bit of a sports analogy. We didn't belabour that smoking's bad for you because most of them knew that. We really talked about little things that they could do, but also some strategies they could build in order to, you know, get into a space of starting to reduce and perhaps quit smoking. So again, you know, this notion of talking to guys about where they're at without belabouring what they aren't doing, you know, what might be perceived as risk. So health literacy can be done by men for others, to help others. And it's the blind spot in the help-seeking literature. You know, we don't talk enough about how guys will do something to help other people. It's really important, I think, in health literacy. I often ask the question, whose health literacy? Because, you know, the veterans example and even the smoking cessation example, it's like, well, whose literacy are we talking about? Are we really talking about trying to help with guys' behaviours and help them get past traumas? I think we are. And so then oftentimes the language they use is different to what we might use biomedically. Meeting guys where they're at, it's long been talked about shoulder to shoulder, community-based. You know, in Canada, it's kind of like a lot of the work we do is community-based. It's kind of the artifact of the social determinants of health here and health inequities. They often get attended to on the ground. And aesthetics do matter. The look and feel of something absolutely matters about whether someone's going to even entertain the idea of having a look at what the content is or what's underneath it, what a program can be for them. So that calling card is super important. There's a little article there. It was a master's student, Carson, who wrote this one, and it's about the Veterans Transition Program. It's worth a read if you've got time, you know, because it does really talk to the way they use language, and it's got some nice outcomes in terms of the very low attrition rate. Like 99% of these guys get through this intensive course. And fingers crossed, you know, touch wood, they haven't lost anyone to self-harm, suicide, you know, in the time that it's been running for now 10 years. I just want to close out with one final point, and this is about thoughtfully considering the design, focus and measure by which we do health literacy. It's super interesting to me. In doing the scoping review, there's no blueprint for this, so it's kind of interesting. I got invited to do this gig in Cologne, and I reckon it was about 2015 or 16. Anyway, it was good. It was gender and health literacy. And so I went to this one, and the guy on my left there is a guy called Richard Osborne. Anyway, really nice fella. And we had a couple of beers and we were talking, and he came up with, he's very well known in your part of the world, with the health literacy questionnaire. And I was so enamored with this because it wasn't about the routine of rote learning or knowing biomedical terms or, you know, knowing your dosage of tablets. It was much more about the interactivity in 9 domains or 9 subscales with 44 items. What I especially liked about it is you didn't have to use all of them. You could do them as standalone. So I ploughed through 6 of them that I really liked, and we ran them on a national survey of Canadian men. We ran the whole lot on another paper with prostate cancer fellows. The good thing about it is that it helps you differentiate different aspects of health literacy, and then it helps you think about the targeting of the health promotion interventions that you might use. So I'm a big fan of it. I think it's great. It's been really good for us. I've really enjoyed using it. The other one I'll close on, just to say, I know yesterday was a big focus on depression and suicide, and we've done a lot of work in that space, and we have looked at health literacy. The reason being, with this one, I believe that if you can destigmatize depression suicidality, suicide, then you have an opportunity, you'll make opportunities to insert mental health promotion. So there's a lot of destigmatizing work, but you can't destigmatize something if people don't understand what it is that you're trying to destigmatize. So we've run these couple studies. People seem to like them. One is gay blokes down the bottom there, where we've looked at health literacy there in terms of suicide, depression, and also in a wider sample, more inclusive sample at the top. And what they've done, we borrowed this depression literacy scale, and there wasn't anything that sort of said specifically about men. So we had to sort of take a few items and then we would insert men, and it was statements. I think what's interesting in terms of the findings, not to belabor the findings, but just to say a lot of blokes don't know. And I love the fact they say they don't know, because I think that's an important finding. So they're not even hazarding a guess here, 20%. And if you look at the suicide one, where we ran the same kind of statements and asked for them to pick true or false, a third of them wouldn't hazard a guess. It's kind of like that the knowledge levels are lower, but they're also, it reflects the taboo nature of the topic. So still lots of destigmatizing work to do here, but to understand that a lot of these guys who are filling this out really, are probably stigmatizing around it because they really aren't au fait with it. One of the things I think we continually do is look for attribution. When we run health literacy, we figure if we can move the dial there, then we can move other things. We ran a network with 6 interventions back in 2013 through 2017, and we did get gains in men's depression literacy, and we did get gains in men's suicide literacy. But of course, there's other things going on in people's lives. So I'm not claiming it as attribution from, if you're exposed to one of those 6 programs, you got those gains. The interesting thing for me in this, and we never published it, but the interesting thing for me was that while we got shifts in the positive around health literacy for depression and suicidality, we didn't get them in terms of help-seeking intent. In fact, we went backwards in help-seeking intent. So just to say, I think the relationship of health literacy to other constructs is super important as well, to not put the pressure on it of standing there alone by itself and something that you kind of hang your hat on completely. So just to close, the health literacy questionnaire from Richard Osborne, it is a really useful pick and pack if you're into the numbers and you want to have a bit of a crack at quantifying some of this work. Gender-specific depression and suicide measures, they are underdeveloped. I felt like we chose wisely with the items that we ran, but that we had to insert men and into the stem of the question just sort of suggests to me that maybe we could do with a bit of a design, a gender design kind of on that to increase it. And also these before and after designs and the use of literacy knowledge items, they do provide only part of the story, but I would emphasize that I think they're an important part of the story, but they don't stand up by themselves. There's a lot of other things in and around. So in a quantitative world, different constructs that we look for associations and relationships, and we'd regress certain things to try and get a better handle on it. But when we're talking to guys too, with the qualitative work, we increasingly pay attention to the fact that, the language they use, so beyond the verbatim quotes, but really thinking about what they use. And we learned many years ago that guys don't talk about depression, they talk about stress. So again, just sort of those subtle nuances about, the language that are used. Thanks again for Glenn for giving me a crack at a speaking part, and just a brief one to introduce the topic, and really looking forward to everything that follows. Thanks again.
So a huge thanks, John, for that really informative and interesting presentation. And it's great to see how your work around men's health literacy has evolved over more than a decade as well, particularly that work relating to men's mental health literacy and or suicide literacy as well. We're now going to move to Leigh, Kinsman, Brendan and Amy, just to have a brief discussion around essentially exploring some of those concepts that John has just spoken about. So what is health literacy? Why is it important? And also, how do we measure that? And importantly, how can we improve it if it needs being improved? So I might hand it over to Leigh to start us on the next bit of the discussion.
Terrific. Thanks, James. And I'm joining you from beautiful Biripi country in Port Macquarie on the mid-north coast of New South Wales. You can see in the background there is where I live. So I'm planning on going for a swim after this. So it's a beautiful place. But John, it felt like we'd shared notes beforehand, because you were saying so many of the things that I've been thinking about in terms of men's health literacy and working on. So you must be on the right page if we're saying the same things. But my own journey is that I'm a nurse by background, and I've always lived in rural and remote areas of Australia, and for the past 20 odd years I've worked in health services research and particularly about how do people access health services in rural and remote areas, and what sort of projects and programs and types of services work in rural and remote areas. And I've come accidentally to the areas of men's health and health literacy, because in the areas that I've worked, I've always found that there is an overrepresentation of men in requiring health services, particularly when it gets to the acute end, when they are requiring either acute mental health services, or they have acute chronic diseases or acute episodes of chronic diseases, that they were then needing the acute services, and we was very much working in the area. Well, how can we work with men in these communities to prevent them actually needing those services in the first place? And in some areas we were working in, some groups of men were 4 times overrepresented in presentations to the emergency department than other groups in that community, and other suburbs in those communities as well. And so over that time, I've worked with farmers who were experiencing drought, and in particular, we developed some men's health programs that were suicide prevention programs because of the high suicide rates there were in those drought-ridden communities. Worked with also men in communities where their mining industries or their forestry industries had closed down, so therefore they'd experienced unemployment, not being able to sell their houses or move to other areas. And more recently, here in New South Wales, been working with the New South Wales Mental Health Commission on mental health literacy, and we've been particularly looking at people in rural and regional areas, and working with men to hear about what they're experiencing and what they believe they need in terms of services, and what they believe in terms of what they need to access and when. So in my journey to then get to where is health literacy important, in conducting the research about access to health services, it became very clear that a person's perception or a community's perception of how they access and understand health information and how they access services is important in us being able to meet them where they're at, which is a term that John used, is that for us to be able to meet a person where they're at and about what they believe they actually need in terms of their own communities. And I spoke then about men who'd lost their jobs in mining or forestry, and they were in some of the poorest communities. Now, this was in Tasmania. And in terms of working with the men in those communities, I did use the health literacy questionnaire as a basis for that, but we didn't distribute it as a survey. We actually did it as interviews. In one of my previous roles, we used to do a number of community surveys, and one of our rules was the 70 rule, was that if we just sent out surveys to communities, 70% of the surveys would be completed by 70-year-old women. And even in some of those communities, now I remember one community that we went to was a community of about 300 houses, so 300 residents. So we as a research team decided we'd actually door knock the whole community and to try and make it a genuinely representative sample. But we'd turn up to houses and we'd say, would you complete this survey? And the husband would answer the door and ask for the and we'd tell him about the survey, and then he'd hand it over to his wife to fill it out. the completion of the survey we based in interviews and used that as a point of connection with the men in the community as well. But as we developed the relationship with the men and used the health literacy questionnaire as a basis, we were able to develop those profiles that John talked about and develop a profile of what was understood and what wasn't, and where there were strengths. It took it away from being the deficit discourse, but what were actually the strengths of the men in these communities, and that was one of the things that was a real take-home lesson was that in the health literacy profiling in the interviews, what we heard were these stories of resilience and strength and local wisdom and an understanding of what their local communities needed. And they often spoke in terms of not just their own health, but the health and well-being of their mates and their colleagues and of their communities. And so we heard these terrible stories about what they'd been through as children or as adults, and the terrible disadvantage that they'd experienced. But still, here they were trying to contribute to their community. So we saw meeting them where they were at and using the health literacy questionnaire actually gave us an understanding as researchers about the things that were important to them and the things that they understood and the things that they thought their communities needed. And the other thing that I actually liked about using the health literacy questionnaire in this particular setting was that it takes into account more than just the medical model of health literacy. It takes into account the social dimensions. And in working, and it asks things like, is there someone in your community that can support you if you need? And unfortunately, in the profiling that we got from these questionnaires, the men were telling us that they felt that they were well supported in their community, but no, they actually didn't feel like they had someone that they could rely on if they had some sort of health crisis. But at the end of our engagement and the profiling through the health literacy questionnaire and feeding the results back to the men, they were asked to come up with a number of solutions to address what they found from the results of the questionnaires, and we fed them back as stories. And the first thing they told us that they needed to be employable. It had nothing to do with health services. It had nothing to do with the medical model. It was that they wanted to be employable. And their first step towards being employable would be to improve their numeracy. So the interventions that we co-designed with the men in that community were about numeracy programs and about other programs that would help them with their own employability. So I found, and so my experience with health literacy and about understanding where they are at and how they access and understand health information has given me an opportunity to address the inequities that, or understand the inequities that these communities have experienced. Is someone coming on? Was there a question there or a comment? I don't know if there's someone coming on there.
Well, what we might do, Leigh, is we might get people to write questions
Sure.
in that box, and then we'll come back to those intermittently throughout the panel discussion. Okay,
good. So I'll wrap it up fairly quickly so the other members of the panel can have a say. But for me, the concept of health literacy was giving voice to the people that are often voiceless. We often don't get to hear the voice of people in policy, particularly about the most disadvantaged. So, men in rural and remote areas, we don't often hear their voice in policy and political discussions about their well-being. So, giving them their voice and understanding where they're at in our research was very important. And hearing from them about the things that they thought could make a difference, actually engage them in those interventions as well. So we saw very strong engagement with the programs that they had contributed to either the design of or the ideas around those programs. And so that were my lessons around how health literacy made a difference to the way people access services and to my research and to the engagement with those particular communities. So I'm happy to take any questions or hand it back to your chairmanship, James.
Excellent. Thanks, Leigh. Listen, we've got one question there which we'll go to before we move on to Brendan, and it's from Margot. And she said she's not a fan of the HLQ or the Health Literacy Questionnaire. And as John mentioned, and Leigh, they've both used HLQ, as have I in one context as well. And there are different and varied ways to measure health literacy. And she's particularly said that she has concerns around the self-report nature of the HLQ. Did you want to just briefly chat about that, Leigh?
Yeah, and look, Margot, you're clearly talking to those that are converted here with the HLQ. So, in terms of the way I've seen the HLQ make a difference is that it's been a means of being able to engage with those particular communities, and in using the HLQ, we haven't distributed it as a survey. We've always used it as a basis for an interview, and that the interview contains more than just the HLQ. A bit like John said, in some of our studies, we've actually only used as few as 3 of the domains of the HLQ to get some sort of profile, but that profile is part of the engagement. So we get a bit of a story, and we get clusters, and we get a profile from the HLQ that becomes part of a story, and the story is what we feed back to the participants in our research as genuine co-design research. And so I've found the HLQ valuable for that, but I don't know that other health literacy surveys would be any less useful in that. I think it's just a means of engagement. And so the self-report side of it is about getting their perspective about where they're at and understanding that some of it might not be completely accurate, but it is part of the discussion, and then their results get fed back to them in the next phase of that co-design and participatory research.
Thanks very much, Leigh. And I think that notion of the way in which questionnaires are administered and what that can look like, that it doesn't have to be a print form or an online survey form, that it might be through an interview format and stuff, can have a really significant bearing on the utility of those particular tools.
Yep.
Listen, we do have another question from Kit, but I'm going to go to Brendan now, and we'll come back to your question, Kit. So we're not ignoring you, but we will loop back. So Brendan, over to you to say a few words around health literacy from your perspective.
Thanks, James. Can you hear me?
Yep.
Sorry, these are new headphones that that my work has purchased, and I think this is actually my first time using them. They seem a bit weird, and I feel like I got a bit of feedback. So let me know if you're having trouble hearing me. But yeah, thanks for having me. I'm speaking to you from very unsunny Melbourne today. So Leigh, I'm very jealous that you're going to go for a swim after this. Oh, sorry. It's absolutely miserable here today. I usually ride my bike to work, but I opted to take the tram. God, sorry, I haven't had my coffee this morning. But just, I guess, to give you a little bit of an idea about me, I'm a public health researcher with a background in drug and alcohol epidemiology. In a previous life, I worked a lot with people who used illicit drugs, primarily methamphetamine. I'm quite new to the topic of health literacy among males, specifically, at least professionally. But I guess my professional introduction to health literacy among was probably in relation to people who use methamphetamine navigating the drug treatment and health and social support sector. A big part of my PhD thesis was focused on identifying enablers and barriers to professional support for people who use methamphetamine here in Melbourne. I recruited a cohort of about 250 people and followed them over time and just sort of talked about their health service use and what helped them access it and what prevented them from accessing health services and professional support. I'm currently a research fellow with the Australian Institute of Family Studies Longitudinal and Life Course Studies team. I work on a few key cohort studies here, including the longitudinal study of Australian children, which is known as LSAC, and 10 to Men, which is the Australian longitudinal study on male health, which is what I'll mainly be giving you a brief rundown on today. For those of you who don't know, 10 to Men is a prospective cohort study. It's one of the largest in the world that investigates men's health issues over time. We collect information across a range of domains, including mental and physical health, sociodemographics, drug and alcohol use, social support, health literacy and service use, of course. Wave 1 was conducted by the University of Melbourne in 2013, 2014, when the University of Melbourne recruited a representative sample of around 16,000 Australian males aged 10 to 55. That group was followed up in 2015, 2016, also by the University of Melbourne, and then the study came over here to AIFS in 2017. Wave 3 of data collection was undertaken in the second half of last year, which was really interesting given the COVID situation. So we encountered a number of problems with that, but the face-to-face component of the data collection didn't go ahead. But to sort of go back to health literacy, I should note that some of the information that I will talk about with you this morning will be explored in more detail by my colleague Neha later this afternoon. I think she's in the 1:45 session, and she has done the bulk of the work on health literacy among Aussie males with the 10 to men data. And anything that I sort of chat to or refer about to this morning is from waves 1 and 2, because the wave 3 data set won't be available until later this year. But I guess just in terms of measuring men's health literacy in the 10 to men survey, we did do this using 3 subscales of the health literacy questionnaire. So sorry about this, Margot. I appreciate you raising the limitations of it. I am at this stage one of the converts, like Leigh mentioned, but I was really pumped to hear John talk about his passion for it earlier. Specifically, we measured the domains of men's ability to find good health information. So can they independently find appropriate, up-to-date, understandable information about health problems? Also, their abilities to engage with healthcare providers. Do they feel able to chat about various health concerns with healthcare providers and to ask questions about things they don't understand or need more information about? And also to measure the extent to which they felt understood and supported by healthcare providers. So, for example, do they have at least one healthcare provider who knows them well, who they can discuss their problems with and who they can rely on? And just to give you a really brief summary of some of the key findings, overall, across those 3 different domains, we estimated that most, so around 80% or so of adult Aussie males had abilities to both find good health information and to actively engage with healthcare providers. The area that we did see the lowest levels of health literacy among Aussie men was on feeling understood and supported by healthcare providers. So just less than half didn't have at least one provider who knew them well, and around 3 in 10 didn't have a provider to discuss health problems with, to use as a source of health advice or who they could rely on. And so I think this links back to what John was talking about a bit earlier this morning about that lack of human connection, which I think can be a crucial component to engaging with services. I guess the bottom line is that there is a significant minority of Aussie men who do seem to have lower levels of health literacy across these 3 domains specifically that we measured, which means that they might not be getting the appropriate professional support when they actually need it. I can touch on the subgroups of Aussie males who we found more likely to experience lower levels of health literacy in a bit. I guess in terms of why it's important, if we don't know where to go, we don't feel comfortable asking about certain health conditions or involvement in risk behaviours, if we feel judged or stigmatised, or we don't know what questions to ask, this can really prevent us from getting the help that we need when we need it. And importantly, Australian males typically engage with health and support services less than females do. So, ideally improving health literacy among males could possibly address this discrepancy. Health literacy among Aussie males is important. I guess it helps us engage and interact with professionals to prevent, but also detect, care for, treat, and all of the above physical and mental ill health. And as I mentioned, while most adult Aussie males have good health literacy, across those 3 domains that we measured anyway, a significant minority are lacking. And the 10 to men data do suggest that many men experiencing health conditions could possibly be alleviated or prevented by appropriate and timely engagement with the healthcare system, didn't appear to be getting professional support. And I think I'm reflecting mainly here on mental health issues. So I guess some of our most important and interesting and concerning findings showed that although men with mental health issues were more likely to be having contact with some services compared to those without mental health issues, many men who were suffering mental ill health were not accessing professional support. And I'm referring mainly here to the Wave 2 data collection. So this is back in 2015, 2016. We'll be having a look at this again with the Wave 3 data. But back in 2015, 2016, only 40% of men with depression had seen, sorry, I'm just checking my notes here, a counsellor or psychologist in the last year. We saw similar figures for anxiety. Also, only 40% of men who'd made a suicide attempt in the past year had seen a psychologist during that time. So, at the same time, over half of Australian males aged 15 to 60 indicated that they'd be unlikely or very unlikely to seek help from a mental health professional for an emotional problem. About half said they'd be unlikely or very unlikely to seek help from a GP. So there does seem to be some resistance in accessing professional support for mental health among some Aussie males. And reflecting on what John was talking about earlier, it is obviously a sensitive issue, and some people experience associated stigma. And this is something that we really need to counter if we're going to appropriately address mental ill health and low service use rates among males relating to mental health. I guess, James, do you want me to sort of go on to some suggestions or some thoughts that I've had about how we address it? How am I going?
Hold those thoughts, because we might come back to those. So if we hold it there, and we might go over to Amy now, for her to talk a little bit around her work in the area of men's health literacy, and then we'll come back and address some of those questions collectively as a group, including those questions coming through from the people that are here as participants. So Amy, over to you.
Thanks, James. Coming to you from beautiful sunny Yagara country in Brisbane, and very grateful to be here and be able to listen to everyone else's sharing today. I'm relatively, it's probably similar to Brendan's, we're relatively new to men's health literacy. I'm actually a public health services researcher as well, and my foray into men's health literacy has come via a knowledge translation pathway. So working in the area of preconception health, there's a fair bit of work in a small but very active research community internationally working in that space, and undertook a literature review of where the evidence is at, and it became very obvious that no one was paying attention to men's health at all in that area, despite there being a lot of original research. There wasn't anyone pulling it together, and there was lots of other systematic reviews being done. And so that started opening up an avenue, I guess, for us realizing that despite this large body of evidence developing, it wasn't actually translating out into community. And then when we started to think about what we needed to do from a health promotion perspective to start to get the message out into community, we realized that we needed to understand what men knew, what women knew, what health professionals knew, and we realized that no one really knew anything about it. The information just wasn't permeating, and because the vast majority of research focus has been on women, some attention to health professionals, men were being largely overlooked or being seen as ancillary. I think a really lovely study that was done from the US has kind of positioned them as being not patient, not guest in any aspect of antenatal care or pregnancy related care, but in preconception space, of course, they're contributing half of the genetic material to the developing baby. And there's actually a good body of evidence that there are some exposures that men have that are increased, that there's actually an increased risk for men who smoke or men who are overweight in pregnancy for certain outcomes than if the woman was smoking or overweight prior to pregnancy. So this information just wasn't getting out there, and we knew that it needed to, but we needed to find out exactly what men did or didn't know, but also really to Leigh's point as well around co-design and also that really lovely example John gave around the cigarette smoking, realizing that a lot of the way that information is being put together is very female targeted, and we actually really needed to realize that that the way that men were thinking about their health, what was motivating them to explore more information and access the information, was going to have to be targeted to their particular way of thinking and viewing and prioritizing and valuing health and their role. And it was a really tricky conversation to start with. So we has started that pathway. We actually developed a health literacy, preconception health literacy questionnaire, which was very specific to the evidence that's currently out there, and collecting some information about that. We've got one of my colleagues in the UK has undertaken some public engagement, and even in that space, they're finding that the materials, that even just taking that idea of just swapping out the imagery and the colouring just wasn't going to work, because the thoughts, what was the men that they were engaging with in the public engagement work in the UK were telling them was that there are things that the women didn't want to hear about that the men did want to hear about. They wanted to hear about the facts and the figures and what were the risks going to be and how that was being quantified, and that was actually going to motivate them to make better choices for preconception health behaviours. Whereas the women didn't want to hear about those ramifications. They just wanted to hear what they needed to do. They didn't want to know what the actual risks were or what the outcomes might be if they didn't do it. So even just in that very simple difference, it's actually a fundamental difference. And so we realised that all those issues that have already been raised about the difference in the type of health professions that they're accessing, the sort of information that their sources that they're getting their information from. We really need to think about that, because we're at a position in time, unlike many other areas of health, where even the health professionals don't actually know a lot about it. The information, the knowledge that the research has developed over time hasn't translated into clinical practice either. So, but that gives us an opportunity to identify who are the people that the men are most likely to access for information sources, and ensure that they have the knowledge that men need to know. Because we can push out a health promotion campaign to educate the men and have a very targeted campaign. But if they actually need to do something about it, they need to go to seek a health professional who can answer further questions. And we need to make sure that those health professionals have the information that they need as well. So it's become a bit of a chicken and the egg element, but we've decided that one of the things that we really need to do to start with is help men to understand that they have a role to play. And in order to do that, we have to figure out what they do know and what they don't know, and how they're best going to engage with the knowledge that we have, so that they can start to adopt better health behaviours and make the health choices that they need to for the future child. So it's been an interesting journey in coming from that public health promotion background and landing very squarely in a health literacy space. That's been it's been fascinating, and really opened up my the whole research area, because it's completely unexamined in preconception health. There's probably 2 or 3 other researchers internationally who have taken the time to look at this and just really taken that process. So.
Okay, thanks very much for that, Amy. That's been really useful. So we've heard today a few different perspectives. We've heard about mental health literacy, some preconception health. We've heard about 10 to men and how health literacy is being captured through that longitudinal study. I'm just looking at a few of the questions that we've got. So going back to Kit, who asked a question before around the health literacy questionnaire. She was asking whether it caters to and supports different learning needs or learning styles. So I guess Leigh or John, did you want to have a crack at responding to that one?
John, I might lead off if that's okay. Yeah.
Yeah, for sure.
Yeah, and I'm lucky enough to be working on some other research with Richard Osborne, who John mentioned earlier, and certainly there's work going on to increase the accessibility of the HLQ to broader audiences. They've translated into a number of languages. I know, James, you've been doing some work about its appropriateness in Aboriginal communities as well. But it's a bit like in health services research, there's a lot of what we do is trial and error, and sometimes it's more error than trial. And I know that in our use of the full health literacy questionnaire, if we've asked people to fill it out at a questionnaire, it's had a low completion rate. And just as an example, we had a particularly targeted evaluation in far west New South Wales, a very remote community, and we wanted to know the experiences of people accessing the local mental health services, and it was an online survey that was offered by both completing the survey online, or you could ring up and be interviewed. And we had 27 men who logged on to complete the questionnaire, and only 9 completed the questionnaire. So they started, but then they didn't complete it, and none of them rang up to be interviewed. They didn't take up that option. So I think there's clearly work that that can be done around the health literacy questionnaire to improve its accessibility and appropriateness for a broader audiences. One of the on the other side of the ledger in engaging with remote communities, that we used in one particular study only 3 domains of the health literacy questionnaire, which I think meant that there were 13 questions in total, and it took about 2 minutes to complete. And we got an excellent participation and completion rate in that case. And so we sort of traded off from getting the breadth of information for getting engagement with smaller domains of the smaller number of domains of the questionnaire, and we managed to get engagement with 600 people living in very remote communities through that. So I hope that answers some of your question, Kylie, and I'll hand it over to John.
Yeah, I think you make some really good points, Leigh. And the only thing I'd throw out there in addition is just to say that Richard's done some work around e-health literacy as well, and just the way the business is going, and it might be reflective of COVID, but increasingly things are sort of going online, right? So with all our community stuff that's kind of shut down for the time. So just to say that adapting the tool to the forum and the type of program that you're peddling out is really key. So he has made some inroads with some of the e-health stuff. I don't know it really well, but the research question that drives it should drive the choice of tool. And if the health literacy questionnaire wasn't a fit for what you were looking at, then there'd be other options out there. But I think increasing that e-health space is one that we've got our eye on pretty close, just the way things are going at the moment.
Thanks very much for those responses, Leigh and John. A couple of other questions there have sort of raised issues around links between health literacy and health service use and/or health literacy and health behaviours. We know that the Australian Commission on Safety and Quality in Healthcare back in 2014 came up with a bit of a definition around health literacy, and yes, it's contested, but certainly it talks about individual health literacy, but it also talks about health literacy environments, and I think we've heard aspects of those today. So I'd like to invite all of the panellists to chip into that conversation around the links between the individual health literacy behaviours, but also the environments in which we can create more positive environments for men to live healthy lives.
Well, I mean, I'll comment. I'm not sure if this directly answers your question, James, but as I mentioned before, we're in an interesting quandary with the work we're trying to do, because no one really knows about the knowledge that we're trying to get across, and so it's just simply trying to engage with better interaction with health services isn't necessarily the answer, because you send a man to access health services in preparation for pregnancy to address some of their health risk behaviours. If the health professional doesn't know what those health risk behaviours are and what the true risks of them are, then they're less likely to provide that level of good information and care. And also a lot of the health risk behaviours aren't necessarily ones that require engagement with a health professional necessarily. Quitting smoking, increasing exercise, eating healthier. They may benefit from support from a health professional, but don't necessarily require it. And so it is a much more of a societal kind of way of thinking. And that requires also a lot of those, the theory of planned behaviour elements of societal norms and those kinds of things, helping to educate all of society about these benefits, so that if men are finding information, looking to make changes, they're not being talked out of them by the people around them. And that particularly again, it requires a good understanding of what the culture, what men's social culture is in the different countries, and how the view of masculinity is, and those kinds of things. I was very interested with what John was saying with regards to the motivation. I think it was John, I'm sorry if it was Leigh, men being motivated by helping others as well. And I think that's a really important point. And I do believe that as health literacy, we need to take that bigger view of health literacy and realizing that there is so much informal healthcare that happens, so much advice, so much self-care that happens, and simply educating people to go to the doctor is not the only aspect of healthcare that needs to occur. There are a lot of other health professionals involved. There's a lot of other health behaviours that don't require health professional involvement at all. And we do need to make sure that thinking about health literacy has that bigger picture view, so that we can optimise every single possible avenue of health behaviour change.
Thanks very much for that, Amy. There's a few more questions that are coming through. So there's a few that have asked around what role does masculinities play, and or a gendered notion of health and well-being. Do any of you want to speak to that notion and how that ties into particularly measuring health literacy among boys and men?
Yeah, I might make a bit of a comment there. And around the specific outcomes that men seem to want, and I don't want to be too generalising about this. So it's only my experience, but my experience about engaging with men and using health literacy as a basis for the engagement is that they often look for something that's quite practical and tangible to be the next step. I've worked with communities that in one community that they wanted to, the men decided that a men's shed would be something that would be quite tangible, practical and helpful for them, and that it provided something that was quite practical for them to engage in. But because they had ownership of it, they had ownership of the way that shed developed and the sort of environment that they would be working in and how accessible it would be and the sort of things that they would do. But it didn't necessarily need to be a shed. I've worked with other people that have used health literacy as a community engagement tool, and they've ended up with things like developing a local football club where they have a weekly barbecue or some sort of sports club or something like that. So it doesn't have to be a men's shed. So in terms of the way I've witnessed men using health literacy information is that they want something quite practical and tangible to come out of it. And I've heard there've been conversations here about men liking numbers and some of the evidence behind a decision and to have ownership of the decision. And I see that ownership of the decision as a really important step.
Do any of the other panelists have any more to say on that topic?
Sorry, James, I might just jump in very, very, very quickly.
Okay.
I have to press like 2 or 3 different buttons to unmute myself. So sorry if I'm a little bit delayed, but I can only really speak to the 10 to men findings, but they did show that when we looked at factors associated with service engagement with a multivariable model, greater conformity to masculine norms was associated with a reduced likelihood of engaging with health services, I think specifically GPs, and that was measured by the conformity to masculine norms inventory. And I guess what John said earlier about meeting men where they are made me reflect on this as well. I guess I think finding incidental opportunities to engage with and educate men might be useful, like an employment context, for example. And I just referring to a question on the chat, Kylie did ask about whether health literacy was associated with service engagement, and the same multivariable analysis, we did find that a reduced level of health literacy on abilities to engage with health service providers was associated with a reduced likelihood of actually engaging with service providers. So the data speaks to that, I guess.
Thanks very much for that. Something that I wanted to loop back to, and again, it's come up in a few of the questions, is when we're measuring or thinking about measuring health literacy, how best do we do that in a way that responds to those that are most those men that are most vulnerable or marginalised in our community? How can we make sure that we're addressing their needs when we're thinking about measuring health literacy, particularly within the context we've heard of education being really important in terms of building functional literacy. We've also heard about the importance of employment in terms of health literacy as well. I'm just wondering if any of you can comment on that for us.
You know, for me, you know, I just recommend that it's like anything, like health literacy is really, you know, a form of health education, because you're trying to get a needs analysis going. And I think it's really tough to do that if you superimpose predetermined items, and especially folks who might not have a background, who might be disadvantaged in a number of social, you know, determinants of health. It's pretty key to know audience. And so I'd talk to them first and get a bit of a sense before I started running, you know, a survey questionnaire, whether it's health literacy questionnaire or otherwise. And I'd say the same with the masculinity stuff. The Conformity Masculine Norms Index, you know, widely used, but it is steeply American. It is steeply Southern American if you look at the items. And again, you know, it's just it's not to say don't use it, but it's to say, hey, you know your audience to begin with, before you start kind of peddling out the antidote or the remedy, you know, based on where the shortfalls of literacy are. I reckon that's just my 5 cents worth. But you know, because I see a lot of blokes that maybe they wouldn't fill out the questionnaire in a way that you'd have a sense that they were literate, but they would be literate in their own way, and that bore out in that scoping review. What they were measuring versus what they were seeing in the qualitative area was quite different a lot of times.
I have to agree with John there. I mean, there's only so much that we can get from the numbers, particularly on a large scale study with scales that might not have been validated in certain subgroups. And there is a lot to be said for qualitative research. And I'm drawing on my experience that I mentioned earlier in working with people who use methamphetamine and who often are quite disadvantaged, and actually sitting down and speaking to people in an unstructured environment and letting the conversation flow and asking them to elaborate on all aspects of health literacy, engaging with the healthcare system, that type of stuff, I think is really, really, really valuable, and probably something that should be conducted before actually conducting something more large scale.
And look, following on from those two, and it's a great question about being able to respond to the most vulnerable. I find in my work, it's the most vulnerable communities that have the least access to the services and are most overrepresented in our hospital system. So an understanding of what they're facing in their own communities it can only be achieved by getting out there and amongst those communities and talking to people. And in our work that was around middle-aged unemployed men being overrepresented in presentations to the emergency department, I went out to the two main communities and two main suburbs that were overrepresented and spoke with the neighbourhood houses about the profile of men that were ending up in the emergency department and how we might engage with them. And the first thing they said was that they won't fill out a questionnaire. And it took 12 months to actually get to a point where we had some sort of trust with the local community, and they gave us entree to the sort of men that we were talking about, because the neighbourhood house used to do things like putting together vegetable packages that they would deliver to homes for men that they knew were living alone and were having bad days and weren't getting out and that sort of thing. So the who we were engaging with was much more important than how many. And so they gave us entree, and it was after about 12 months we were able to start to have some. We ran some barbecues and we ran some other community events that the men that we were wanting to engage with were comfortable in coming along and meeting the research team. And over a period of time, they actually didn't recognise us as researchers. They were just part of their community and working with them. But working with the very closely with those communities, that were representing and understood the needs of those most vulnerable was really important in getting the who we engage with rather than just how many surveys we got completed.
Thanks very much, Leigh, and John, and Brendan and Amy that have contributed to that conversation. I think that there's a lot more work that can be done in that space in terms of how we go about measuring health literacy, and certainly doing that from the ground up, working with those populations that we're working with. Does anybody want to notice that there's a comment from Glenn there around, I guess it's around the maturation of health literacy, both nationally and globally. He goes back to some of the work of Don Nutbeam talking around the functional health literacy side of things, and so forth. Did you want to comment at all around where we've come from, say 20 years ago, to where we're up to now, and what the future holds? Where can we go next?
Spot here, James. Speaking for veterans, to have them do a survey, they'll all be very sceptical on what the outcomes would be. So it's very difficult to do that with the service personnel. And when they've put in a program now, as a person is discharged, they do go through a detox coming out of ADF to find out how they stand, where they go, and that sort of avenue, and what they can do in outside society, because walking around with a gun in your arm through the bush doesn't give you a working job out in civilian street. I know it took me 18 months to settle down, and I had a trade. So yeah, there's to get the information from veterans is very hard, and to get them to settle to find out how you can help them is also very difficult. So as I said yesterday in Glenn's session, was that you have to get their confidence in you on how you're going to handle them, because they're an individual. They have different traumas, they have different needs, and there's not enough done out there professionally as well for the veterans. So it comes down to volunteers like us, who ex-service people, trying to help them out with their difficulties. And it does take time, because I've been on the DVA this morning for over 1.5 hours trying to get information for a person. So yeah, so this increases their agitation, depression, anxiety, which creates their suicide attitudes, because the information and what's offered to them outside is very difficult to get hold of sometimes.
Just, I guess, elaborating on that, I think it was a question, who was it from? Nick Hansen, which was around, we often focus the health literacy discussion on male help seeking, but how does that extend to other concepts that sort of sit within a broader social determinants of health realm, in terms of accessing financial help, engaging with families, engaging with the legal system and those sort of things, because we do know that they are a precursor for suicide ideation. Do you have any comments on that?
Just a shout out, James. One spot, just a quick one to say, it's a bit of a random thought, but talking about military, the way that the guys are recruited into the Veterans Transition Program here is that they go to the guys, they say, oh, there's nothing wrong with you, you're all right, but there's some blokes at the group that could really do with a hand. And as unethical as that probably is, it's an example of appealing to a literacy around camaraderie and having your mates back that's well known in military code. So anyway, you just prompted my mind around that. In regards to the inequities one, James, it's a great question, because we talk to guys in the downtown east side here who are challenged by homelessness, substance use, and poverty, and they have to be literate in so many different areas, because there's a separate service for housing, there's a separate service for welfare, there's a separate service for health, there's a separate service for mental health. And they tell us, because we wanted to put a physical intervention, like a more physical activity program for them. And they said, we get plenty of physical activity. We're going from service to service. We're walking north of 20 Ks a day, just getting what we need. It's a full-time job. So it's just, it's an interesting thing to think about in terms of what we say we need to be literate about, because you've got to be literate about the services and the system to, in any way, shape or form, be able to address the inequities, right, as an individual. And I'd love to see a one-stop shop somewhere where there was one queue and you could get it all done, but they're few and far between, especially for the deeply marginalised populations that do require those things. So it's certainly something to think about in terms of literacy.
And I think that actually does relate back to James's question before about what's the next step in this, because I see health literacy as a really important foundational principle for how we move away from the medical and health services model of health. I think in Australia, my experience is that we're seeing the inequities increase. We're seeing gaps increase between the haves and the have-nots. In general practice, has become a private model of business where the general practice will follow the money and not the demand. So we're seeing the people in rural and remote areas that have greater needs actually having less access to general practice. And something like health literacy, where we meet people where we're at and we understand what it is that they believe around their own health and what they need, can bring us back to those social determinants about what are the things that make a difference to their community and what are the things that make a difference to them. And that comes back to your interactions with the justice system, legal support, housing, all that sort of thing. So that sort of thing, I think health literacy can make a big step in understanding the social determinants as a foundation for health and take us away from an increasingly privatised medical model of health.
Looks like Glenn's got a question.
Yeah, I mean, something really just landed in my mind then when John was sharing about the unethical approach to nudging blokes into support, which also linked back to what Brendan was sharing about measuring masculinity using the conformity to norms scale, which also then links right back to your starting point, John, when you were talking about the deficit model. And it just struck me really powerfully in terms of that translation from research into practice. In practice, what we're often doing is we're listening out for an unwritten scale of masculine strengths, like mateship and camaraderie and the willing to give help, even if you're, these are the things that practitioners talk about, classic one yesterday, Mates in Construction, very well-known program based on the core principle that men may not be great at getting help, but blokes love to offer help. And the whole program is predicated around men's value and strength around offering help, which could be measured and positioned as a masculine strength. And so it's really interesting for me to, what instantly comes into my ideal world head then is like, how in literacy can we measure strengths that pre-exist that we can work with, rather than seeking to measure deficits that we need to try and correct? Because there's a big difference between sitting down with a bit of paper which says, right, okay, from a masculinity perspective, it's conformity to traditional norms, which we now need to correct in order to get men to be healthier, and sitting down with a list of here's a proper evaluated list of masculine strengths that we know we can work with to help men engage more effectively with their health and health giving systems. So I just wondered if you could do a little bit of work in the next couple of weeks, creating a global kind of masculinity scale or masculine strengths and values that we can tap into health literacy when you've got some spare time, John. That's my question.
Yeah, look, I'm glad you said that, Glenn, because I'll get right onto that. But Leigh said that he might beat me to it, so I'm gonna leave it with him. And I think James actually had a bit of a nod in the chat to it as well. So I'm in some good company here.
Yeah. Absolutely. Listen, I do want to link back to this notion of peer-to-peer support. So we've heard that that's really important within a veteran space. We know that it's important in other spaces, and particularly with boys and youth. There's been a lot of peer-to-peer health promotion work going on. And I noticed that Jackie has put a question up around, what about boys' health literacy? How are we measuring that? Is there anything out there? I know that that Richard Osborne and Shandell Elmer and Rosie Nash have had concerns around that we're not good at measuring health literacy within that younger cohort. And I guess I'm wondering whether any of you, particularly maybe you, Amy, doing work in the preconception space, whether that's ever filtering over into that sort of newborns or boys health literacy space as well.
Absolutely. There's a huge focus in preconception health research generally around the life course approach, and very much that try to find ways of getting exposure to concepts around preconception health, but also improving health behaviours in the adolescents before people really hit reproductive activity and becoming commonly sexually active. So there's absolutely work done in that space. What's interesting is most of that work is focused on health behaviour change to achieve better outcomes over preconception health. Whereas what's not, and there's less work done, although still some work done on how do we actually cut into getting the message across and tailoring that message in a way that's going to be receptive to, and mostly it's being work done in schools. And most of that work is being done in schools in lower socioeconomic areas, which is really great. Going back to the points before about reaching out to marginalised areas, marginalised populations, I think that is one of the most powerful areas. We do already have some level of sex ed in schools, and just trying to get those points across. And it's a relatively captive audience. Of course, we still don't have 100% school attendance, but it's an opportunity to get messaging across and provide education that relates to all aspects of health, and particularly in the topic of preconception health, because it is probably, it's an interesting conundrum, because it's not actually an illness-focused conversation. It's actually very much a health-focused conversation. It's about being as healthy as possible and minimising risks that may not be causing direct health problems right now, may be health problems in the future. So really trying to tap into them when they're quite young to be able to address that, so that, and help them be motivated to make better health choices. So they have definitely done some of that work. And they found that they're having to really tailor those conversations in the school ages. They haven't gone much younger than that. So it's mostly around high school. It's kind of getting to that 15, 16-year-old age group where people are starting to become more sexually active. And it's an interesting conundrum as well, because they're trying to also prevent unplanned pregnancies. And so there's education around not, creating a pregnancy. But there's also trying to get some information out there about when you do plan to, there's good positive health behaviours that are important to be in place at the time. And so managing that conversation is in a very different messaging than if someone's in their mid-20s or early 30s. There's a real delicate balancing act around that. Yeah.
Thanks very much, Amy. I think that's a really useful contribution. Wanted to come back to the national men's health strategy. So Australia has a national men's health strategy. One of the actions in that is to increase health literacy. But listening today, we've heard that, I think, Brendan, it was you that said that 80% of men understand health information and so forth based on the work that you've done. So is increasing health literacy the right action that we need in the National Men's Health Strategy, bearing in mind that it's a 10-year plan, so it's not going to be updated probably till 2030. But what could that look like in the future? Is it more around building a deeper understanding of health literacy among different groups of men? What could that look like? Silence.
I'll jump in super quick and then let the others speak. But I do think that that's one of the things that's a effect of the research that's happened over time. And Leigh made a great point that so much in health services research is there's, unlike so many other areas of clinical research, health services research is a predominance of information around women and what women want and what women expect. And I don't think health professionals are really trained to target their own messaging and conversations in clinical contexts in a way that's reflective of the motivations for different genders. And I think that that's probably, there's as much about, when you talk about increasing health literacy, it's also increasing health professional competence. And I saw a really great comment before, do we need to keep focusing so much on teaching men to understand the language that health professionals are using? I think we need to really make sure that the health professionals are using language that means something to the patient and to the men. I think that's a really important element of it, and it's the way that the language in the National Men's Health Strategy is phrased doesn't capture that, doesn't provide enough responsibility of that to the researchers and the health professionals to provide messaging that actually means something to the community that they're trying to talk to.
And some of that, I think, comes back to, and somebody just picked that up in the conversation around that notion of having health literate organisations and health literate professionals, people that can engage men on their terms in their way. Brendan, I think, were you going to say a few more words on that?
Sorry, James. I can really only speak to the data. I mean, I go back to the for our, whenever we produce something here at AIFS from using sentiment data, I always go back to the National Men's Health Strategy to work out, well, because a lot of the time we're speaking to policymakers, so I'm trying to work out if what we're going to produce is actually relevant to them. I've become quite frustrated because I don't think that the National Men's Health Strategy is particularly comprehensive across a whole bunch of different areas. And I'm not, to be honest, I'm not particularly familiar with how much it covers health literacy. But I just think, going back to what Glenn was saying before, if we're only focusing on what people don't know, and I think that it's important to focus on what they do know, and why they're actually accessing services. You know, even though there might be lower rates of service use among males, you know, that's not, we don't have to be forcing everyone into service use all the time. There are other avenues that we can be addressing health concerns and implementing initiatives and education. What I can say is that our data showed that there are specific subgroups of people who are less likely to have health literacy across those 3 different domains that we assessed. And so those included people with less education, those with more financial hardships, people without private health insurance, also people who live in non-metropolitan areas, so rural and regional areas of the country, and younger males. So that also, I guess, speaks to what we're talking about with trying to access people from a younger age as well, and have that discussion earlier on about health literacy among people before they reach adulthood, I guess.
Excellent.
James.
Don, yep.
If I can just cut in, I just want to go back to Annie on one thing that she was talking about. One of the things that Westmoreton did, and I'm in Turrbal country on the north side of the river, but one of the things we did in Westmoreton years ago in the 90s was to put in school-based youth health nurses, and they did a lot of education at that level for high school students. That was a good project until we had a change in government, where the government felt that chaplains would be better served than school-based youth health nurses. The other thing I want to talk about was Spot was talking about veterans and the health system and GP practices. It's a very good comment that, yes, the system doesn't allow, it's about a business, all that sort of stuff. But in my practice in the last 5 years, it was about working the system to make it work for veterans. So it's using all the MBS billing numbers to make sure that your veteran got the best care that they could. That's probably all I needed to make mention of, just to bring those subjects up. And the other thing we're talking about, I think that was hinting on, there's a plus paternal network research that's been done by Healthy Male. And I believe Glenn Garth Kendall will be talking about that on Thursday. And I'm just probably pushing my own agenda here that I'll be on a panel discussion on Thursday where I hope to be talking a lot more about how we can service veterans and the service that we can give to them. Thanks.
Thanks very much for that, John. Listen, we're about to come to an end here, and I just wanted to give the opportunity for our speakers to say a final sentence, concluding sentence, and then I just wanted to share some information around a special issue of the Health Promotion Journal of Australia as well. So, John, did you have something to share with us as a concluding comment?
Just a sentence of thanks. Really enjoyed the conversation, and these are important things to discuss. And I'm glad that health literacy is alive and well, and that we're talking about it in such forthright ways.
Excellent. Leigh, did you have any final comments?
Oh, look, just to thank you again for the opportunity to speak here and to hear what's going on, and just to come back to that mental health strategy, the men's health strategy that you spoke about, and about the aim to increase health literacy. I think it's more about how do we use and understand health literacy, and how do we meet men where we're at, and how do we then inform policy that becomes more nuanced about the different needs that different men in different communities have. So thank you.
Excellent. Amy?
Yes. Yes, also, thank you very much for the opportunity to contribute today. And I think my main take-home message would be, I think, just like many other areas of health, we need to make health literacy research and interventions much more person-centred and move away from it being health service-oriented work. I know that there's definitely work happening to do that, but it's just a hangover from years of health service-oriented delivery of health. And person-centred health literacy is something that I'd like to see more of.
And thanks for that. Brendan, did you have any final comments?
Thanks, James. No, I'd just like to reiterate what others have said, and thank you very, very much for people who pose the questions, but also everyone who's involved in the discussion, because it's discussions like these that I think are really useful. I don't feel like, COVID happened, but, I don't think as someone who crunches numbers and writes papers that we have enough of these discussions with the people in the know, and I think that's really, really, really valuable for informing future work output. So I'm really thankful for that.
Excellent. Thanks very much. Thanks very much for coming together for today's session on building health literacy among men. I did want to share with you that to coincide with the Men's Health Connected set of events that the Australian Men's Health Forum has organised, that the Health Promotion Journal of Australia has it's a virtual issue on strengthening men's health promotion in Australia. All of the articles are online free until the end of July, so please get on and have a look at that. I think there's about 20 articles or so in that special issue, including ones from many of the presenters today. So I just wanted to say a huge thank you, and I'll hand it back to Glenn if there's any final words that he wants to say.
Thanks, James. Thanks for steering an excellent session there. I am just going to pop in the chat box a link to that online journal, which is it's free to access, but for a limited period only. Is that right, James?
Till the end of July. So it'll be right up until after International Men's Health Week and so forth, and all the events throughout May, June.
Yes, so grab it now while stocks last. You have a limited period. I know there's an excellent introduction there written by some fella called, it's me. There we go. So I made a very small contribution to that process. James, thanks for making that journal happen. And thank you for steering the excellent conversation today, helped by 4 superb speakers. Thank you, Brendan. Thank you, Amy. Thanks to John. And my brain has just gone blank. I realize Leigh. Thank you, Leigh. It's the first time I've met Professor Leigh Kinsman. I'm really interested to hear you speak, and hopefully, Leigh, it will not be the last time that we engage with you and your work. And thanks for all the participants who made a huge contribution to the discussion. Some great questions, some great contributions. And a really good start. I think I know more now about health, men's health literacy and health promotion than I did 90 minutes ago. I hope that's the same for everyone involved. And I'm reminded of Leigh's comments there at the end. It's not just about increasing men's health literacy, it's thinking about how we use it as a tool for particular communities to engage and to actually improve their health and produce services and systems that actually work for men in their communities. So we are officially now on we're 1 minute into an official 15-minute break.